The last company that we're going to talk about is Medtronic and their tool OptiVol. So OptiVol is a fluid index that looks for the accumulation of fluid in the chest. And the way it does that is it, similar to CoreView, looks at the difference between the daily impedance and the reference impedance, the thoracic impedance. So a thing to note when we're looking at OptiVol is we usually see two trends, as you see here. So the top trend is OptiVol fluid index, and below it is your thoracic impedance. So the thoracic impedance is what drives your OptiVol fluid index. So when we talk about thoracic impedance, we say higher is drier and lower indicates potentially worsening heart failure. OptiVol is the opposite. So if you have a higher OptiVol or an increase in your OptiVol fluid index, that shows that we have worsening or more fluid accumulation. So here's a situation where, May 2016 or so, we see the daily impedance drop below the reference impedance trend, and you also see those spikes on your OptiVol fluid index trend. Okay, so of course, it's true for all of these don't replace clinical assessments of your patients, but it is helpful as kind of a clue or a little bit more insight into what's going on with the patient. Something else that's really great that Medtronic has is TriageHF. So this is a compilation score from multiple different sensors. So it looks at the OptiVol fluid index and your patient activity. It looks at episodes of atrial fibrillation and if there were any ventricular arrhythmias that were shocked or treated. And it looks at heart rate. So night heart rate variability, heart rate during AFib, and then percent pacing. And what it does is it compiles all of this data into like a risk stratified score. So it's going to assign patients as either low risk, medium risk, or high risk. And that risk is what's their risk of having a heart failure decompensation event. So what the data actually shows is that if a patient is classified as high risk via the TriageHF algorithm, that means that they have a 10 times higher likelihood of being hospitalized for heart failure in the next 30 days. So really important if you have a high risk score patient, really important to act on those. But medium patients could be potentially at risk too, right? It's a 2.1 times higher likelihood of having a heart failure hospitalization in the next 30 days. So not insignificant there. And then your low risk patients, we can feel pretty strongly that they will not be hospitalized in the next 30 days for heart failure. So this is a unique feature that, again, takes a little bit of the guesswork out of it. Instead of just looking at the trends and saying, is this increasing? Is this decreasing? It will actually show kind of what is the risk score. And what's nice, as Keith will show in a moment, is that it shows which sensors and which, pieces of information are contributing to that risk factor. So what I want to do next is as I mentioned, Keith is going to take us through our fourth and final case study, but we're going to do it a little bit differently. Instead of just, posting screenshots, he's actually going to take us through OMNI, which is our device clinic management software platform that we use to help device clinics in a number of different ways. So Keith, if you want to take over the screen sharing and show us OMNI and show us this patient, that would be great.
Thanks, Kate. So as Kate mentioned before, this is our software. This is our device clinic management platform. And we're going to take a look here at a patient who is borderline with TriageHF. So here we can see that this patient is at medium risk. And as she mentioned before, it tells you why on the side right here. So the concerns are patient activity, AFib, ventricular rate during ATAF, and your night ventricular rate. So it's always important to have the clinical context for the patient, and it's nice to have as much of that information in front of you as possible. So we see this patient's on AFib. One of the first things we want to make sure is, are they anticoagulated or not? We can look up right here and see, yes, they are anticoagulated. That was recently checked in the EMR to make sure that's updated and accurate. We also can see this patient is followed for heart failure. And so that'll allow us to know, how we want to report, if we want to report to. We can look at the previous transmissions to see if there are any notes or things, that have been mentioned previously. And then also the patient has been scheduled. So when you look at this patient here and we want to look at the different indicators here, we can see OptiVol is not, very concerning at all. It's barely registering here on the bottom. The thoracic impedance is fairly stable. But the really big thing is the patient activity. So you can see this just drops down significantly to go from, almost 2 hours a day to basically they're barely moving at this point. And the biggest concern with these heart failure patients is are they symptomatic? Are they feeling it? And that seems to be a dramatic change. And it very much correlates for when they went to AFib. So even though this is a medium risk patient, the fact that they're very likely to be symptomatic, we don't know until we talk to them, but all the indicators here suggest they will be. It's probably someone that we would want to escalate. So I think, we want to make sure we indicate all that here in the summary, maybe even send a note to the physician so they can see, why we're concerned, and then definitely rank this patient as someone who needs attention.
Yeah, great. Thank you. Thank you, Keith. And I don't know if I don't think you touched on the scheduling, if you wanted to just talk a little bit about that.
Oh, absolutely. So I think the other concern too is, when we're working with these patients, we want to make sure that we're monitoring at the appropriate times, that things are billable, that we're not overbilling the patient, but also have an idea of when they're coming in. So in this case, this patient has 2 care cycles to make sure that we have them coming in, and that they were due today, they'll be due again in April, but they're also being monitored on a separate track for heart failure, and that one's due on the 23rd. So the fact that this patient has almost no activity and they're coming into a new AFib for them, I think it's more appropriate that we alert now and not wait until the 23rd to talk to the physician.
Yeah,
And Keith, I
definitely.
think another nice thing about this is it highlights, how everything we've been talking about throughout this is it's not just one data point, right? And if you look at the first clinical study, what did we see? We actually got alerted for ATAF, right? And here again, if you showed that example here, it looks like the patient, based on their anticoagulation history, has probably been being followed for AF for quite a while. It's probably been well controlled, and now they're having some breakthrough AF, right? And we know through clinical data over time that there's a direct correlation between, a patient's, having recurrence of, atrial fibrillation and the likelihood of having heart failure and vice versa, et cetera. So, as we look across all of these and as people look to manage their patients across the clinic, there is no one sort of silver bullet that's going to tell us, hey, this patient is at more risk than the other, but it's really, as everyone's emphasized here today, a need for looking at this holistically and looking at all the data points,
Yeah, great. Thanks. Good insight, Greg. So as we wrap up, takeaways we had for today, Greg, you just summarized them all really well, that, the device-derived diagnostic data for heart failure is helpful, but we want to make sure we're not using it alone. And some devices are making that a little bit easier for us by showing trends together and automatically compiling the data into that, risk factor or the composite index score. And I think we're going to continue to see more and more of that over the coming years. And of course, it's, remember, in order to be beneficial to the patient, using this data, it's really critical to not only understand what is the data telling us, but when to act on the data and when to wait a little bit. So, through these case studies, I think we've shown when there are certain alerts in certain conditions, like the one that Keith just went through, where it's a medium risk, but we probably should act, versus some other ones where maybe we want to wait and see what happens with the patient over time. I think it's really important to understand that, and that's not easy. It's definitely some art, and it takes a lot of experience and a lot of help from all the resources around you.